What lessons can Iran teach the United States about how to best get donor organs to those who need them? Transplant nephrologist Benjamin Hippen addressed that question at a Cato Policy Forum held February 21, 2008. This is a segment of a longer event available at cato.org.
So what lessons can be gleaned from the Iranian system of organ vending? First, organ vending affords the opportunity to procure more organs from all sources. The track record of the Iranian system offers assurance that an altruistic system of organ donation from living donors and deceased donors can readily coexist alongside an organ vendor system. Indeed, as Virginia Postrel has had occasion to observe, it's simply morally obtuse for people to declare that they will not become organ donors because of opposition to organ vending, since that harm is simply visited on otherwise innocent third-party recipients. For those opposed to organ vending, one more organ donated is one less organ which needs to be purchased. Furthermore, recipients with moral objections to receiving an organ purchased from a vendor need not pay for that moral commitment with their lives. Instead, those recipients can request only receiving an organ from a donor, and donors who plan on donating at death can stipulate that their organs may be procured only if they're not subsequently sold. Good outcomes for vendors have both moral value and market value. I've argued that ambiguity regarding the outcomes for organ vendors is morally unacceptable, and the burden of assuring safe practices falls squarely on transplant professionals and policymakers. This obligation to assure safe practices can be traced to the general obligation of a physician to avoid doing harm to patients. For both donors and vendors alike, providing a clear and evidence-based understanding of the long-term risks of exchanging a kidney are paramount for achieving authentically informed consent. This can be readily accomplished by offering comprehensive lifelong health insurance to every organ vendor, which in turn can be the vehicle for a donor registry. The vast cost savings of transplantation compared to dialysis, as well as the low overhead costs of ensuring a cohort of explicitly cherry-picked, low-risk organ vendors, makes this approach a more fiscally responsible use of taxpayer dollars. Kidney vendors with undetected pre-existing kidney disease or risk factors for the same are much more likely to incur higher health care expenses, and a system which selects organ vendors, those individuals least likely to develop short and long-term complications, is by extension most likely to maximally reduce overall health care expenditures. If that entails excluding the poor from opportunities from organ vending, so be it. An organ vendor market does not purport to be the solution to poverty or to the plight of the uninsured. It is only a solution to the shortage of organs. The non-interference right to sell a kidney does not, all by itself, imply an obligation to buy. 3. The harm so prevalent in underground organ trafficking can be avoided by a clear separation of responsibilities. Physicians and transplant professionals should be able to focus on the medical, surgical, and psychological suitability of donors and vendors, not the recruitment of vendors. And likewise, organizations responsible for vendor recruitment should not be involved in making final determinations on the suitability of vendors and should not be incentivized to cut corners. It's worth lingering for a moment on why this discussion should matter to those of us in the United States. In our country, there is a present and growing disparity between the demand for and supply of transplantable organs. And in 2006, some 4,000 of our fellow citizens died on the list waiting for a kidney. And from 1999 to 2006, some 30,000 potential recipients died waiting. Only 20% of all patients with kidney failure in this country are listed for transplantation, and only 4 to 5% of all patients with kidney failure in this country are transplanted on an annual basis. And our federal government spent some $21 billion on kidney failure in 2005, of which $2 billion went to transplantation. Some 6% of the entire Medicare budget went to 0.6% of all Medicare beneficiaries. And for this is for a therapy, maintenance dialysis, in which the 5-year survival is 35%, whereas the 5-year survival for recipients of a transplant is 75%. Successful transplantation improves quality of life, quantity of life, and at a fraction of the cost of maintenance dialysis. And the lessons to be learned from the Iranian system are toward the end of reducing the suffering here and around the world inflicted by the cruel contradictions, perverse incentives, and manifest failures of the current system. A parting thought. 3 years ago, Dr. Matus, Dr. Delmonico, and I had the privilege of listening to Dr. Ibrahim Rivzi address the World Transplant Congress in Boston. Dr. Rivzi, the father of nephrology and transplantation in Pakistan, and a well-known outspoken opponent of organ trafficking, pleaded with the attendees, and I'm paraphrasing, but he said, please Please convince your patients to stop coming to Pakistan and buying kidneys from the most destitute of my fellow citizens. Do what you must. Increase organ procurement from deceased donors, institute a system of presumed consent, whatever, but please, what is happening in my country is also your responsibility. And on that point, Dr. Rivzi is correct. What is happening to his brethren is very much a part of my moral responsibility as a transplant physician, which is why I support a regulated market in organs in the United States. You see, the disparity between the demand for and supply of organs in countries such as the U.S. has wrought a flourishing underground international network of organ trafficking. Dr. Delmonico's organization, the WHO, has recently estimated that some 15,000 transplants around the world, some 10% of all organs transplanted in the world on an annual basis, occur through organ trafficking. Why? Because for those without an available living donor, the waiting times for organs in countries such as the United States and Canada now frequently exceed the median lifespan of those on the waiting list. It is the recipients of means in developed countries who travel to places such as Pakistan and the Philippines to purchase organs from those living in debt peonage, which provides the core economic support for organ trafficking. There is no press conference, there's no position statement, there's no debating point which alters this brute fact about the legacy of failure of our current system. In response to that failure, people are voting with their feet, whether it is by soliciting organ donors on the internet or by engaging in organ trafficking. Ladies and gentlemen, the current and existing failures in developed countries to effectively address the organ shortage has resulted in a terrible moral complicity with organ trafficking. The challenge at hand is this: will organized transplantation hold transplant recipients around the world hostage by inaction, ineffective half measures, or empty platitudes? And should cynicism regarding the political will of our elected officials to exhibit a modicum of courage in overturning the National Organ Transplant Act, or fears of bad press, or some other such thing, serve as a legitimate excuse for not striving to change a policy that continues to engender needless suffering and death here and abroad? Or, as I hope, shall we finally arrive at the recognition that the theoretical concerns about organ markets are defeasible and that the alleged costs of an organ market to human flourishing ought to be understood in the context of the conspicuous costs in persistent human suffering, needlessly lost human life, and squandered public treasure of more of the same?
Benjamin Hippen is a transplant nephrologist. Full event videos are available at cato.org.